Now, moving on to the fourth section, that is the shock. In this section, we will be briefly going over the different types of shock, what is initial response to trauma of the body, how to assess what is type of a shock, and how to manage that specific type of a shock. So what is the initial response to a trauma? If a body has suffered from trauma, what usually happens is there's maybe a direct injury to the blood vessels, which could be, there could be a formation of vascular patch, there may be associated arterial vasospasm to reduce blood loss. But sometimes if there is a major arteries involved, arterial spasm may not be enough to decrease the blood loss, and they must be associated with significant blood loss, leading to hemorrhagic shock or hypovolemic shock. Once the shock has occurred, there may be fluid redistribution as well. So usually associated with endocrine responses stimulated, there is a release of vasopressin and glucocorticoids such as hydrocortisone as well. And this may be associated with falling basal metabolic rate. There is increased oxygen delivery as well towards the vital organs such as the heart and the brain, and there may be increase in the tissue oxygen consumption as well. So this is usually what happens when the body is suffering from that kind of a shock. So basically what happens in the shock, there is a reduced cardiac output. This could be due to impaired performance. This maybe is a common cause is a cardiogenic shock, in which the heart is unable to pump enough blood so that the body can utilize it. So there is failure of cardiac function, and usually follows apparently a minor insult to the heart. Now if you take the example of pericardial tamponade, now what happens is there is a collection of blood in the pericardium so that the heart cannot pump its normal blood to the body. This is classical example of a cardiogenic shock, which is leading to impaired performance of the heart, and so that eventually leads to a shock. Then shock could be due to impaired venous returns. Now this is usually due to hypovolemic shock, in which are hemorrhagic shock. There is a fall in the circulating volume and critical hypoperfusion occurs. For example, there was an injury to the pelvis as well. There is a massive bleed in the pelvic region. This has actually reduced the circulating volume, and this may ensue a hypovolemic or hemorrhagic shock. Now coming to obstructive shock. Now obstructive shock is there the venous return is actually compromised. Although there is no decrease in the falling volume of the venous return which is coming, but somehow there is an obstruction at the thoracic level which is not causing enough venous return for the heart to return, so that this results in obstructive shock. This may be raised intrathoracic or pericardial pressure, and CT angiography for initial investigation may be required as well. And the classical example of this type of obstructive shock is tension pneumothorax, in which is actually the problem is with the lungs, but it's the tension and the pressure is so much that it's actually obstructing the venous return to heart, eventually leading to shock. So what is reduced systemic vascular resistance? What happens in there are other types of shocks as well. That is neurogenic shock, which is usually associated with spinal cord injuries. For example, this leads to hypotension, but along with associated bradycardia. Normally in a shock there is hypotension associated with tachycardia, but in case of neurogenic it's hypotension associated with bradycardia. Other types of shocks could be anaphylactic and septic shock. Now in anaphylactic septic shock there is usually peripheral vasodilation, and eventually fluid shifts such that there is increased fluids moves out of the vessels, eventually leading to hypovolemia and redistribution such that there is decreased venous return. Therefore, it may be associated with hypotension and tachycardia. And in case of septic, there may be severe sepsis, which may be associated with systemic inflammatory response syndromes as well. Now, how to diagnose shock? Clinical examination is important, which could be in if it's involving the cardiovascular system. The first and foremost is the pulse. Usually there is tachycardia, blood pressure is low, that is hypotension. GVP is usually false, heart sounds may be muffled in case of pericardial tamponade, and peripheral perfusion is decreased. But only it's in this systemic shock, such as septic shock or anaphylactic shock, there is usually increase in the peripheral perfusion. If you see at the respiratory system, respiratory rate increases, there is associated tachypnea. There may be increased work of breathing. Tracheal divination may be associated with obstructive shock such as tension pneumothorax. There's decreased air entry on the one side with hyperresonant percussion note. If you see the abdomen, there may be due to hemiperitoneum, the patient may be in the shock, which may lead to pain and distension, peritonitis, and localizing sign may be present as well, associated with decreased urinary output. Now coming to the central nervous system, in case of neurogenic shock, what happens is there is usually loss of consciousness associated with peripheral neurological signs that the power and reflexes are maybe diminished or completely absent as well. Now the problem is with usually there is hypotension, bradycardia, and associated loss of consciousness. Now the other system which gets affected are the temperature and skin signs, which may be seen in case of anaphylactic shock such as rashes, and other as could be lame as well. There may be peripheral hypoperfusion or maybe hyperperfusion in case of septic or anaphylactic shock. So how to manage and the shock? The algorithm is through the first initially the monitoring is through the non-invasive ways, as you check the heart rate, you check the pulse, you check the breathing rate, and you check the urine output. If it is decreasing, you early recognize it because the BP is going down and the pulse is rising. This is probably the sign that the patient is in shock. Early resuscitation must be done, and if it keeps on deteriorating, then probably we have to go for invasive monitoring. But if it has improvement, then we have to keep on monitoring the patient. How to basically analyze this is through the history, observation, clinical examination. We can use ECG, BP, and pulse oximetry. Again, early recognition is through that we have to check the BP, the pulse, and the urine output. This will tell us the deterioration in the patient systems. Once the invasive monitoring can be done as well, sometimes for the decompensatory shock as well, such as blood dictator may be required, CVP and arterial monitoring may also be required as well. But usually, once the patient is stabilized, there is highly less likely that you need invasive monitoring. But if the patient is continually deteriorating, then probably we require invasive monitoring along with the aggressive resuscitation. So what are the different ways by which we can monitor the patient from if patient is suffering from shock? These include pulse counter analysis. This was shape of an arterial waveform, which was usually the catheter was placed in the femoral artery, and it usually gave us some analysis with how much the cardiac output is, and regarding what was the BP, what was the pulse, and what was the rate, and how much it was coming out. It was through the transpulmonary thermodilution technique. But nowadays it's been utilized pulse power analysis, which is actually a lithium dilution cardiac output monitor, nomogram of patient demographics, and you don't need to insert any peripheral arterial line. So it's more of a non-invasive monitoring and gives us hemodynamic data of the patient, what is happening in the patient actually. Now coming to the management of shock. Management of shock starts again through the airway, breathing, circulation, disability, and environment. We have to give, if it's a hemorrhagic shock, usually it's considered, in case of a trauma patient, considered a hemorrhage shock until it's proven otherwise. So for that, you have to give fluids. If you are still not able to resuscitate, then we may have to give blood as well, because the patient is losing a lot of blood. Inotropes and vasospacers are only kept for, especially in case of a septic shock may be required when the patient may be going into severe sort of sepsis and hypotension. Then inotropes and vasospacers have a role as well. Endocrine support in form of vasospasor and hydrocortisone are utilized, but that are only in form of septic shock. And systemic support means actually giving monitoring the patient in intensive care, so that if whatever happens, we can quickly react to that. Now, there's a different types of shock or different types of treatment. For example, if it's hypovolemia, the control of the hemorrhage is important, and the control of hemorrhage is through the putting pressure on if it's bleeding from somewhere. Then is the restoration of circulating volume in form of fluids and blood products. If it's obstructive, and usually obstructive is due to tension pneumothorax, then the initial treatment is needle decompression of tension pneumothorax, and eventually maybe requiring a pericardiocentesis. If it is due to cardiac tamponade, or thrombolysis, surgical removal of pulmonary embolism if it is caused due to pulmonary embolism. Then coming, if it's a cardiogenic shock, for example, if the heart is failing and is unable to pump blood, then probably will require inotropes, antiarrhythmias, revascularization, aortic balloon counterpulsion, and maybe surgical valves of the lesion may be required as well, but that is only once the patient has been stabilized initially. Then comes the distributive shock. This is usually associated with anaphylactic or septic shock. So the initial treatment is the infection, and then maybe leading to abscess drainage and early antibiotic and admission as well, along with the supportive management. In this section, we have briefly gone through what are the different types of shock. This could be obstructive shock, such as due to cardiac tamponade or due to tension pneumothorax. It could be cardiogenic shock, which may be associated with the problem with the heart as itself. It is unable to pump enough blood, or it could be hypovolemic or hemorrhagic shock, which is usually most commonly associated with trauma in which there is massive blood loss leading to hypovolemia and hypoperfusion. Or this could be in form of a neurogenic shock as well, that is in which there is injury to nervous system leading to hypotension and bradycardia. Or there may be associated septic or anaphylactic shock in which there is hyperperfusion in the peripheral lines along with hypotension and tachycardia, and along with these things like that. The management of shock is through the ATLS protocols. To maintain circulation, we have to give 2 large IV cannulas, give fluids, and if may need blood products as well. Depending upon a different specific type of shock, specific management should be initiated. Thank you very much. Keep watching sqadia.com.